All right, so good morning, everyone. I'm recording this just on behalf of those who wished to attend but were unable to make this time work. I'd like to introduce you to Dr. Christopher Lickshai and Madonna Ferrone from Best Care. We're going to hear a little bit of a capsule summary of the program and then start into some conversation around logistics to getting this program started for heart failure in the Great River OHT region, particularly focused on practices without funded allied health. With no further ado, I'll pass it off to Madonna and Dr. Lickshai.
Well, good morning, everyone. Thank you, Marilyn. It's a pleasure to be with you today. I'll be presenting Best Care in Primary Care, or Best Care Canada, a proven and measurable value-based chronic disease management model of care. Just a few words of introduction about who we are and about Best Care. It is a frontline clinical program. It's operated by a not-for-profit corporation. We have a community board of governors, and you see our 6 governors here. It is funded through various streams by the Ministry of Health, and we are currently serving almost 400 sites across Ontario. So this is the Best Care approach. First, across the top thematically, Best Care is an effective model of care for chronic disease management. It is a repeatable platform for multiple chronic conditions, and we have learned that Best Care can be a mechanism or a tool around which leaders like you can build out health system transformation. More specifically, across the bottom, what we do is outlined here. Really, this is a complete knowledge translation, team-based care package. So from the point that you say, yes, I want Best Care, usually just within a few weeks, we can be working side by side with you, supporting the care of your patients in your practice. We're embedding educator case managers who are guideline experts into the patient's medical home, into the health home. So these are registered nurses, registered respiratory therapists that can work side by side with you as a team member supporting the care of your patients with chronic disease. It is proactive, preventive, and upstream care, and I'll show you some evidence around how we're reducing hospitalizations and emergency department visits and improving the quality of life of patients. An important element of our program that is proactive, preventive, and upstream is that we have validated electronic health record searches that we can support you to do in your practice. These are searches that have been developed by quality improvement decision support specialists, those teams that work with family health teams to do EMR searches. What we can do is identify those high-risk patients, curate a list for your review, and then before those patients arrive in the emergency department or the hospital, we can invite them in for a comprehensive assessment, if you will, for a tune-up around their chronic disease management. And I will just highlight a couple of examples around health system transformation opportunities. Here's some of the members of our teams. I think we have now more than 60 educator case managers in this community of practice, registered nurses, registered respiratory therapists who are certified respiratory educators, cardiac educator case managers who really become guideline experts. This is a one-of-a-kind community of practice. These are team members that work across the province of Ontario and more recently now some sites into Quebec and British Columbia, and they're supporting each other in the delivery of care and, of course, supporting you in your practice. In a clinic, this is how it works. First, just to reassure everyone, if you haven't heard from colleagues about Best Care, it was designed by primary care providers to work in primary care practices. Last year, we did 30,000 visits in primary care. We've done well more than 100,000 visits in primary care practices. It works in primary care. It adds no work to primary care providers. It does not add clinical burden. It reduces clinical burden. It reduces administrative burden. It really does work. So this is an educator case manager who's seeing your patients in your practice under your supervision. After identifying patients and inviting them into the practice, or after receiving a referral from you to see the patient, they will leave with all elements of evidence-based best practice, including on-site spirometry, pre and post bronchodilator if it's a COPD patient to help to confirm the diagnosis. They'll get a self-management action plan. There are elements of case management, including immunization. I'll share a bit of that with you. At the end of a comprehensive review in your practice, the educator case manager will spend an hour or so. They really will look for about 3 minutes of your time on that day where they can tell you about your patient, what they have found, what are some of the opportunities to advance the care of the patient, whether that's pharmacologic or non-pharmacologic management, and then execute on all of those elements with your permission on your behalf. It is not a 6-week program or a 12-week program. We are embedding educator case managers in the long term for a continuing care relationship. Well, I'm going to speak about heart failure and COPD today with a focus on heart failure. This is really an approach to care for multiple chronic conditions. We do have a heart failure, COPD, asthma program. We will have a severe asthma program specifically laid out. We have started doing lung cancer screening. I can share just a bit of that with you today, time permitting. Well, let's move to a discussion about heart failure. This is a program that we initiated now many years back. Dr. Bob McKelvey is a heart failure cardiologist who has been our specialist lead in this area. This is one of Bob's slides, and this is a little bit dated. It goes back to 2018. The gray bars are 2018. And at that time, the recommendation for managing heart failure reduced ejection fraction was that all patients should be on triple therapy, an ACE-ARB-ARNI, a beta blocker, and an MRA like spironolactone. It's showing in the population that around 6% of patients were actually on triple therapy within 6 months of receiving a heart failure diagnosis. It's important to titrate people rapidly because it does improve quality of life, it does reduce hospitalizations and ED visits, and it does extend survival. So as a province, looking at performance out to 6 months where 6% were on triple therapy wasn't really adequate. In our experience now, looking at our best care heart failure program, somewhere probably closer to 10% of people are on the current recommendation for quadruple therapy. That means 90% are not across the province. Whoops, sorry. The current guideline recommendations are that patients be on quadruple therapy for heart failure reduced ejection fraction. And they've removed the sequencing element. It used to be kind of start ACE-ARB-ARNI, add beta blocker, add MRA. But now you can add whichever medication you want in whichever order, whatever makes sense for the patient. But the goal is 4 drug therapy titrated to the target dose or titrated up to tolerance. So if the potassium is high, that may restrict your titration of the MRA, for example. If the heart rate is low, we may not get to the bisoprolol target dose, but the notion is to make those efforts and to do it with some speed. When 15 or 20% of people are dead at the end of a year after their heart failure diagnosis, it's important to get this done promptly where possible. One of the challenges I think that we identified as we launched the program was that heart failure cardiologists or cardiologists believe that this responsibility for titration falls in the primary care sector. And once a patient is under the care of a specialist, in general, primary care was taking the view that the management of the heart failure was in the hands of the heart failure or the heart failure cardiologist. In fact, there seems as though there was a gap in between that, and that may be why we're seeing that 6 to 10% figure from the province. What we published last year in the Canadian Journal of Cardiology Open was our initial program results. I'm not going to take the time to go through the busy graph, but currently our performance metrics show that 60% of patients with heart failure, reduced ejection fraction, that we are managing with their primary care provider in primary care practices are now receiving guideline concordant care with quadruple therapy. So not 6% or 10%, but 60%, and this number will likely continue to grow. What we expect when we're managing heart failure along clinical practice guidelines is that we would dramatically improve quality of life. In fact, that's what we have found in this simple pre-post analysis. Almost all patients, 85%, had an improved or stabilized quality of life, not declining. In fact, we showed reductions in hospitalizations and emergency department visits that were highly statistically significant. I know the focus today is on heart failure. I do want to show a couple of slides on COPD because our hope is that as funding permits, we would be able to also support you in the management of patients with COPD. When we look at pharmacologic therapy for COPD, currently 80% of patients in the Gold E category, these are people with COPD who have been admitted to hospital in the past year or have 2 or more prednisone or antibiotic requiring exacerbation. The current recommendation is triple therapy, inhaled corticosteroid, long-acting beta agonist, long-acting antimuscarinic agent. Currently, 80% of the patients in our program are on this management. The impact of that, similar to the heart failure parallel, based on this randomized control trial we did comparing best care to usual care in 4 family health teams. But in the best care population, there was a dramatic improvement in quality of life. Almost all improved their quality of life, and the mean difference was 9 on the CAT score scale, which is a very large improvement. On the control side, over a year, there was no change. In terms of the provincial health system, last year in the journal Thorax, we published an interrupted time series analysis. The panel on the right here shows 2,400 best care COPD patients, and we had connected the patient's OHIP number to the provincial data set. In this study, what we showed was that for 3 years before we ever met the patient, there was an increasing rate of hospitalization. We also looked at emergency department visits related to COPD, all-cause hospitalizations in emergency department visits. We looked at primary care visits for COPD, and what we in fact saw was the same inclining trend for all 4 of those indicators. Once patients entered the best care program at time 0, what we then saw was a dramatic reduction in the rate and a change in slope so that over the next 3 years, there was a declining rate in hospitalizations, ED visits, and primary care visits. So if you will, a first in the world, real-world analysis of team-based care or integrated disease management for COPD in primary care practices, published in a high-impact journal, Thorax, showing a sustained improvement in health service reduction for patients in best care. This year, we did add a vaccine enhancement program to the offerings for best care. So this is part of the case management aspect that I talked about. This does show first that it is recommended. These vaccinations are recommended by our international guidelines and by the CDC. When we look at our current performance, somewhere around 70% of patients have the pneumococcal vaccine, have annual influenza vaccine, but we feel there's an opportunity to improve those rates beyond where they currently are, and additionally to add a shared decision-making conversation about RSV, shingles, make COVID a perennial discussion, and to step up to Prevnar 20 for those that are interested, able, and willing. And so we've launched the program to do that in this past year. We have also initiated lung cancer screening following the same pattern. Our international guidelines add lung cancer screening to COPD because of the common risk factor, because that COPD is an independent risk for lung cancer. We initiated this program in October of 2004. We're now operating in 4 regional cancer programs supporting primary care to do active lung cancer screening as part of the COPD care that they are delivering. We do measure everything that we do. We do report that back to you and share it with you. But I can tell you just a little bit about the lung cancer screening program. So far, we have approached 2,400 patients in the Best Care program. We have done on-site risk calculation using the PLCO calculator so that we're referring only those patients for lung cancer screening that actually meet the risk criteria of greater than 2% risk of cancer in the next 6 years. These are the people that are eligible for low-dose CT scanning. This was a major learning for us looking at our COPD population because many people are talking about an average risk in the smoking group. And when we say 1.5%, it may not sound that high unless you happen to be one of those 1.5 or 2%. But here's the 2% line in our COPD population. Every dot on this scatter plot is a real person. And so Best Care, working with primary care, I believe will change the lives of many people at risk for lung cancer. For example, this person's risk is a 1 in 3 risk. This person's risk is almost a 50% risk of getting lung cancer in the next 6 years. Every one of these people has been now connected to the Ontario Lung Screening Program, and because they are all eligible for annual low-dose CT scanning, we will be changing the way cancer is diagnosed from late stage disease 3 and 4, where the treatment options are few and cure is generally not possible, to stage 1 and 2, where cure is a reality.
Can I just jump in just to clarify that,
Sure.
Chris? So our history in our region has been that it's quite easy to make a first step referral to the lung screening program in Champlain, but the delay has always been at that second stage where the nurse calls and does the screening. So just to be clear to the clinicians who are on the call, the Best Care program, when we bring in this COPD pathway, will actually do that second stage screening. So when the referral actually gets sent into the lung screening program, the second step's already done, and these people are directly set up for CT as if they'd gone through so they basically skip a step, which is a huge improvement. And I know both Winchester and Cornwall have relatively quick turnaround times for the lung cancer screening component of their CT programs. And with Glengarry hoping to be approved in the short to medium term for a CT scanner, that could really advance the opportunity in our region. So I just wanted to make that very clear for the specifics to our OHT.
So Marilyn, I just want to clarify, we're not there yet.
Okay.
I'm working with Andrea at Ottawa, and there is a little bit of logistics where they have to consent the patient. So we are working through hopefully having to skip that step or fast tracking them so that it can be done quickly. So I just want to clarify, we're not there yet, but we're working on it.
Okay. And then to be fair on that one, if there is an opportunity to leverage the ocean system that most of my practices have for that consent document, then that could actually improve the ability for us to share the documents that the program might require electronically rather than necessarily continuing on the old fax train. So
Yes. I
Awesome.
think we have been in conversation, as Madonna alluded, with OHCCO about program process changing. but working with regional cancer programs to fast track and facilitate in the way that you described. And in London, for example, we do still fax a requisition, but there is a fast track process with the coordinator, the navigator. They still have to do this consent because that is the requirement, but we're working with that. I think in London, for example, we still have improved efficiency, but there's another step to undertake yet. I wanted to share this part, Marilyn, because I do think it's related and parallel to what you're planning, what your team is planning in your region, and that is the North Bay example. The timeline here, I think, can be accelerated, but just going back to 2022, we initiated Best Care Heart Failure in the North Bay region. We did in 18 months with one educator case manager, did 800 visits in 300 heart failure patients. Now every clinic in the region participates in Best Care. We have then added Best Care COPD when funding was available. Now we're doing Best Care Heart Failure, COPD, lung cancer screening, and early diagnosis of COPD. And all of that happened in a 2-year interval. I think we can accelerate that as funding becomes available. Across the province, we now have about nearly 400 sites, 1,700 primary care providers. We did 19,000 spirometries in primary care practices, and we have spread the geographic envelope from north to south, southwest to southeast in Ontario. So really, to close this part of the presentation, Best Care, proactive, preventive, upstream care, delivering guideline-directed medical therapy, proven and evidence-based with now more than 20 peer-reviewed publications. It improves integration in care. It is scalable at the health system level. We've earned the trust of about 1 in 5 comprehensive primary care providers in the province. It is a repeatable platform. It is cost-effective, better care at a lower cost, and it supports primary care as the foundation of our future resilient and sustainable health system. I'll close there and turn it back to you, Marilyn, and to you, Madonna.
Thanks so much, and I appreciate the finer details. It's certainly wonderful to see, and yes, COPD is definitely on our radar. But small tests of change are generally better taken up at the beginning and then the larger rollout. So, Madonna, I'm going to hand it over to you to talk logistics. I know you're just in the process of onboarding the individual that you've hired, and as you know, we've got representatives from Alexandria, Cornwall, and Akwesasne on the call. Oh no, Vina's still here. Thanks.
Yeah, so we're ready to go whenever anyone is. And her distance to Alexandra and Cornwall is the same. So we can go to both areas with the same person. So I think it's just understanding each of the sites, how many physicians per site, and then from that perspective, we generally will divvy out the resources. So, for example, if one site has 3 physicians, generally that can be started at 1 day a week, but then it usually goes to every other week. If we have a site with 5 or 6 physicians, usually we can go once a week. So honestly, Marilyn, we are ready to go. She is in her 2nd week of training, would like to go on site to finish up her training. So what happens is a coordinator will go sit with her and see patients on site. What are the logistics of making this happen? We have an EMR access agreement, and I'm not sure if Ali has sent that through, Marilyn, so maybe we can. No, okay. So there's an EMR.
Yeah. So I would have to share that with all the practices that are interested. I mean, some of them are co-located in one version, so hopefully not too many signatures needed, but.
Yeah, so the EMR access agreement, sometimes it's the lead physician who signs, sometimes it's every physician. It's really up to the physician group to decide how to sign it.
Mhm.
Sorry, I didn't plug in my computer and it's going to die on me. Um, so once that is signed, what happens is so it's really the pleasure of the physician group, but generally, we become part of that circle of care with the patient. We can run these searches that Chris alluded to. They're simple searches. We generally get a good uptake on them. And then we show each physician their list, and then the physician approves or doesn't approve. So nobody is called unless you, as a physician, approves it. And then the calling depends on your site and what you would like. If you don't mind us calling, we will call on your behalf and set up an appointment for the patient. Or some sites, they prefer their front staff to call. That's I have to actually say, I don't think any front staff calls, because that's extra work on your front staff and we don't want that. So we call, we book the patient in, and we see the patient, and Chris explained everything else to you. If they are seeing a cardiologist, we will work on that shared care piece with the cardiologist and make sure that if they're seeing them and they give a plan, we follow that plan together, but then communicate back to the cardiologist that this is done and this is done. And of course, that's on your behalf. Other than that, it's that simple. We come in, and right from the beginning, we need a room and we need access to your EMR. That's all we need. Sometimes a printer if you want to see your list printed out. That's it. Once let me just tell you, once we're done seeing the patient, you have signed off on everything. You're the prescriber, so you send your prescriptions off. We upload our report into your EMR and a plan of care into the encounter note, attach anything that needs to be attached. So everything is in your EMR right there at your fingertips.
Any questions? Because I think that's the most important part of this conversation.
I have a question. Can you talk more about the documentation? You mentioned writing something out and then uploading it to our EMR. So my one question is do you actually type anything into the EMR, and are you using the E2P toolbar?
Good question, Clara. And I remember you now that I see your face. um, so so as you know, we have our own electronic medical record. We have a report that pulls everything we do is tick boxes and drop downs and radio buttons. All of that is on a report. That is what is uploaded. The plan of care is really the meds, the action plan, any referral that you want. You work with the case manager and it's decided they need to go here or here. That is written in the plan of care in your chart. So we actually copy and paste it from our tool in. There's no double documentation. As for the E2P tool, we have been working with them so that for heart failure, your blood pressure, your heart rate, your diagnosis, so what type of heart failure, your ejection fraction, what we have in our note will automatically be put into the E2P tool. So we don't even have to do duplication. It'll be put right into your tool on that day. So for heart failure, if we can organize it where you actually poke your head in and see the patient, then because from a billing perspective, that helps from that perspective, and it's all done there for you.
Now, to
We
be
are
fair,
close to having that. They had some issues. They've been working on it on their end. They're having issues with getting it automatically uploaded, but I think we're close.
and to be fair, they're doing the first test of change with TELUS PS Suite. And Clara, I think you're Oscar, correct? Yeah, so
Yeah.
our first test of change for the new integrated data process would be with a PS Suite
Yeah.
group. They're gonna test it in an existing site elsewhere in the province as their first pilot area. But I think Claire Miller, your practice, your whole group is PS Suite, so then we could do a test of change with them. And then I think, if your group is interested. And most are in your group, I think, or your whole group is on Oscar, correct? Your clinic, I mean, not
Yeah.
necessarily your foe, but your clinic is on Oscar, correct?
My clinic, yes.
Yeah.
Yes.
So so then we could maybe work with you to figure out what that data needs to look like for an Oscar site, because I know that Madonna's team and the Center for Effective Practice, who owns the toolbar, are interested in making sure that all these programs are interoperable. And the easiest way to do that is to write the documentation in your EMR from that copy paste in a format that actually is readable by your EMR. So in PS Suite, it's BP colon 122 over 73. And then it would actually pull. In Oscar, it might be different. So we're going to have to build it based on the way Oscar would read data in the EMR compared to how TELUS reads data in the EMR.
But Clara, I mean, if you use that actual form for your patients, and it is part of your billing also for you to do that, for us to input you know, 5 items is not that big of a deal until we get this going.
I haven't, it's on the list of things to do is to download the E2P toolbar and
Yeah,
start using it. So it hasn't been done yet, but we're working on it.
it's okay. That's a common answer, so don't worry. But
And
we can work with you is where I'm going with that. We always work with what you need um, for what you want to see.
And we have a practice facilitator from Amplify Care, someone we've seconded part-time, who is part of that process. So, those digital supports. Angela's coming to your office, I think, sometime the week that she's down the end of September. So she'll be able to do some hands-on with that if you don't get a chance to do it yourself between now and then. So between now and the end of fiscal, we should be able to get all practices that are interested up and running on the toolbar.
But it also sounds like even if people aren't ready to go work on the toolbar, they can still start working with a best care practitioner.
100%. Yeah.
And
Yeah.
we
You
And
will
we'll
make
get
continue to use the paper flow sheet or the PDF flow sheet, however
Yes.
you've been using it without the toolbar.
Yeah.
we have made a commitment this year to Ontario Health to continue our work with E2P and explore new collaborations. So this sounds like an opportunity to really to do that. So another example of where we could work together.
Yeah. Awesome. Awesome. Well, I'm continuing to advocate for this program, primary care practices and HIS systems that have the E2P best practices embedded in their order sets to actually create that platform through the E2P toolbar to be that collaborative communication tool. So no longer do we have to do, the heart failure. Tag your it. I did this. Now it's your turn. Tag your it. Let's get away from that.
Um,
Questions for Akwesasne, because you guys have some unique challenges based on geography and data governance and that sort of thing.
Yeah, for sure, because we work like our half of the population is on the Quebec side and half in the Ontario side. So with jurisdictional barriers,
No, actually,
we have that problem. So I don't know.
actually, we can help you with that. The person we
Uh-huh.
hired has a French license and an Ontario, has a Quebec license and an Ontario license.
Wow,
Uh,
perfect.
yeah, we're really excited about that opportunity with her.
Mm-hmm.
Because she will also be doing Huntington, which
Mm-hmm.
is on the Quebec side also.
Awesome. That would really help us because that's the
And
only
she's
barrier,
finding
like the huge barrier for us.
Mhm.
And
I didn't know we would help you on that barrier, but I'm happy that we are.
so
Well, we'll
Madonna,
figure out something, I guess.
the only other proviso that you may want to look into in terms of your insurance is in
Mm-hmm.
order to access Akwesasne's Quebec clinic, they have an
Okay.
Ontario location, but on the island, but then to get to the Quebec location, which is their main office, you actually
Yeah.
have to go through the US. So Madonna, it'd be useful for you to look at your insurance in terms of, if heaven forbid they had a car accident in that little stretch of US Highway 37, what would happen? So that's the
Okay.
only
I
other
did
little
not know
proviso.
that.
Yeah.
Okay. Thank you for that.
Yeah. So for now, I would propose, Vina, if the Department of Health decides to proceed, then I
Mm-hmm.
would propose that we would start with using your location that's with your elder care center, that new clinic space that you've built. Um,
At Sinai, or
uh,
are you talking about the island?
on the island, that's at
Oh,
the
okay.
yeah, that new spot that we were going to use
Mm-hmm. Mm-hmm.
um, the IPC money if we had gotten some. But we could start there as they sort out their whatever insurance issues they may have to sort out. It may not be an issue, but I wanted to raise that as oh, you have to send an employee through the US. That could be a challenge. So
Yeah,
Yeah.
true.
I can say the border there is not a problem if you just say you're going to the clinic in Akwesasne. And once Alexandra has gone through 10 times, they're all going to know her, and it's like, yeah, bye.
Okay.
Any questions from any of the other physicians?
Just a quick one, if you can tell us how it would usually work when it comes to booking appointments. How long is the appointment typically? The physician, I imagine we have to be at the site, when patients are seen, so we can, maybe discuss the case right after. Let's say if I'm in the clinic and then I'm also seeing my patients, then do I have to book some time, to review the case, in between patients? If you can maybe just tell us about, the logistics and how things flow in the clinic.
Want
Yeah.
me to take a crack, Madonna, or do you want to answer that?
It doesn't matter. Go for it, Chris. We've trained Chris very well. He can
Yes. No.
answer all these questions.
Uh, so we, in general, where possible, I think it's ideal after the educator case manager has done the review, and that's generally they're going to spend about an hour with the patient if it is a first visit. Once they have finished the review, it's ideal if they have a few minutes to meet with you to review what they have found. Um, and they really are trained to find a time that works for you. So, yes, we do try to schedule the individual at a time when you're in the clinic. If it's a group practice, and say there are three physicians or four physicians, and we have booked 5 or 6 patients that day, maybe one of those patients, possibly two of them would be yours. So we would be looking for a 3-minute window somewhere in your day where we could review that patient and what we have found. Um, the value of that in-person encounter is really that it allows the care of the patient to happen right at that point in time. So when they leave, everything is done. Um, so the other value in having that encounter is then you get to meet the team member, you get to meet the educator case manager, and it's a trust and confidence building opportunity for you. So you can say, yeah, this person really does seem to know what they're talking about. They're a highly skilled professional. I'm starting to trust the recommendations they're providing to my patient. So there's a lot of value in that 3 to 5 minutes. And we probably need that once a day when the educator case manager is there, something like that. On the other hand, clinical practice is clinical practice and it's busy. And sometimes if you're running 30 minutes or 40 minutes behind or whatever, and you just don't have time, we'll be connected to the EMR. So we can send a message through the EMR to you about your patient and the recommendations. We can find you at lunchtime when you have a few minutes, if that works for you, and discuss the case. That's the sort of usual approach. We do want to make it work, and we do not want to be disruptive in any way.
Yeah.
Great.
I just might add, I mean, sometimes at clinics we've started where they say, I want to book that patient in right after you're done with them. That lasts maybe a month, and then they say, we're not going to do that anymore. So it's really your pleasure as to how you would like it to be done. But when I did this, if I really needed something and we really needed something for the patient, I might wait for you when you're done in between and take a minute from you. Because once you get to know this person, you know exactly what we're coming for. Sometimes in heart failure, they'll see you in the morning and tell you, oh, I'm seeing this person and this person, that's yours. If all is good, can we then go, up the beta blocker? Can we start this? And you've already decided. So if all is good, they say to the patient, okay, we're going to do this. And then the meds are sent after. If something is wrong, then they'll stop it. You know what I mean? They won't do it, and then they'll have a follow-up conversation with you. So it's however it works in your clinic. We really don't take extra time from you other than that quick connection. If nothing happens to the patient and all is good, they might just say to you that day at lunch, I saw Susie and whoever, and there's no changes, all is good, everything's uploaded on your EMR.
And can we select patients, that, these are priority patients? I know I'm seeing patients now in the next month or so, and it's just basically start building the list instead of, doing a complete search. And some of them are probably followed by the cardiorespiratory clinic that probably wouldn't benefit from this, since they're already, seeing by nurse practitioners and possibly also a cardiologist there. So can we just start doing that instead of doing the initial search and then we would have a list of a couple of hundred patients and
Well, we're talking
It's
only heart failure, Youssef, not
yeah.
not COPD at this
No, I
point.
know, I
yeah,
know, I know, but they are
yeah,
if they are at the cardiorespiratory, they do a lot of them are followed for CHF.
Mhm.
Yeah,
yeah.
so
So it's up to you.
yeah,
It's you. The
if
other
you have
thing,
a list
Marilyn,
and
we probably should look at though is discharging some patients from those clinics that don't need to constantly go to a hospital or be followed as often. So
Agreed.
that's
I
something we could look at.
I can say that we at the St. Lawrence Medical Clinic, when I worked in Morrisburg and Ingleside, we did not have COPD and heart failure in the same way that Madonna and Chris's team offers it now. But we did have a lighter version of that, and we will be looking to upscope those nurses who are doing that in the Rideau St. Lawrence Family Health Team to support that neck of the woods in the short term. But we did have this in a fulsome way for diabetes, much the same as what we started with the PCN nurse program. And I can say, first of all, with scheduling, they became side appointments. Literally, it was as if I had a double booking, and I would just specifically talk to the nurse, and the nurse would say, we've made these I'm suggesting these changes to the medication. The patient needs their blood work. If you can just sign the rec, because the rec would have been filled out in the EMR, and I just needed to double click on it. These prescriptions need renewal. And oh, by the way, they've got a sore shoulder. Can you just pop in? And from my perspective, for diabetes, at least, it was really critical that I popped in because then you can build a KO30. But for heart failure, if you're going to eventually build a QO50, you need to have seen the patient twice in a year minimum, right? So worthwhile going in, talking to them for 5 minutes, validating what the coordinators already said, because then you're building that concept of trust with the patient in the team. And so, doing that at least twice a year with your heart failure patients will give you that A007 or whatever, so that you can build a QO50 once you do the flow sheet. That's been my experience, but literally 5 minutes unless something is totally sideways at the appointment.
Just a quick comment to reinforce the message, Yusuf. If you have a list and that's your priority, that's our priority.
That's great.
Yeah.
Great.
Awesome. So probably the next step then is for me to connect the people that are on this call and the others who were unable to attend directly with Madonna, with you or with Allison.
Just put me, Allison and I both on it.
Okay.
Ali was off today, so she will help with the nitty gritty on the front line.
Okay, just for those who might get an email from Allison, I've forgotten her last name now.
Keller.
Keller, yes. Just so you know that it's probably about best care. And then what week are you looking to get this started?
And anytime.
Okay, so if you want to
Honestly, we could start tomorrow.
okay,
I'm
so let's
we could start
let's plan
Monday.
for next week, and if you guys can look at your clinical space capacity, and if you can come up with, what are you thinking, like 2 or 3 people for the first visit in each office?
Yeah, I mean, 4 usually in a day for the first, until she gets up and running, and then it'll be more after that.
I
Right.
think just to, if you jump in on the in terms of the initiation, Madonna, and you can correct me. So once there's a yes and we have a signed agreement, then the educator case manager and the coordinator can come in, meet at the clinic with the doc or the office manager or whoever coordinates logistics and just sort the logistics. If an EMR search needs to happen, that can happen, and sort of in prep for that first clinical day. So there's usually a meeting on site prior to initiating the patient visits. And so the coordinator and the case manager would come on site and meet with you to make sure the logistics are sorted, and then patients would be booked. So there'd be one other step in there.
Okay, perfect. So maybe then it's more a look at your schedules for when you can have that first coordinating meeting sometime in the next week or two. And then let Madonna and Allison know.
That'd
All
be
right.
fantastic.
Yes. And Vina, happy to have you connect directly, or if you would, I'm going to share a copy of this recording. So if you wanted to pass it along to any of your clinical people, like your nurse practitioners or Dr. Horn, or to your senior managers at the Department of Health.
For sure. Thank you so much.
So could I ask, I can't find my little button to put my hand up.
It's all good.
I know Lucy's on the phone. We're kind of still have in the very, very beginning section for our group. Who's going to reach out to us and for a site visit? And when is that? Is that what you're just?
I'm just suggesting that you reach out. I'm going to connect everybody in an email thread.
Virtually an email.
So
Okay.
then you can then advise Madonna and her colleague Allison what day in the next couple of weeks would be good for Alexandra and their the manager to come out and meet with you and whoever else to sort out some of the logistics for Alexandria, because Alexandria has primarily that one location in the hospital, but then there's a couple of other opportunities like Dr. Lajoie's clinic, etc. So then you have to figure out the logistics of who goes where and when, and how often, and it's going to be a complicated schedule. The individual's name, my understanding, is Alexandra, so that may be a little bit of a yeah.
Honestly, all we need is for you to say yes, look at the EMR access agreement, and then let us know what days work best for you. Like if you have a room available on Monday, Tuesday, and Friday, let's just say, then Ali will fit everybody into a schedule. How many are at your site? Primary care providers. And she will take care of everything. And then if you have a point person at your site that she could talk with, it's honestly that easy. And then when they come to see you, it's just really kind of introductions in the clinic and so forth. We will work through all the logistics. Generally, we meet the docs and it's literally a 2-minute hello. This is, whoever. And then it's usually less than an hour time of your admin person just to help us get set up and get things organized. We're pretty good at setting up clinics and not being intrusive.
And they need one place that they always come to. They have to have that one site, or they don't go to different offices.
Yeah, we go to different offices. That person will be shared across the region.
No, but I mean in our site, like if this person comes to Alexandria, which they will, they would like one place, or can they go Tuesday, my office, Wednesday, Lucy's? I don't know. Is
right.
that possible?
Nope, it's the latter. Yes, we want to be on site with each group. So that's where let's work that through with Ali. Our goal would be one day with your group, another day with the other group you just said. That's what we want to do.
So in my mind, that group that's at the hospital, there's 4 or 5 of them. Am I correct?
It's 5.
Right. So there may only be, so on one day, so-and-so's office is being unused, right? Dr. Marlowe's office is empty on Wednesdays. So there's a space for this individual to work that is not intrusive on your clinic flow. And they can use that space, and the patient they can have co-appointments because they're all like closely located, right? Dr. Lajoie's office, of course, is on the other, down the road. So for her, she might have the resource a lot less frequently because it's one practice rather than 4, but it would really depend on the volume of patients, right? So I think
okay. Yeah, that's good
right?
then. Yeah.
Yeah. So then that way, because otherwise it doesn't make sense because Lucy would have to uproot her practice to come to the hospital. That doesn't make sense. It needs to be co-located with the practice. And this is why it's so valuable in Cornwall, where the practices are dispersed across the town, across the city. And so, Dr. Sharda's group in Cotton Mill and Dr. Lee's group on Montreal Road are going to be 2 different locations. And again, the data will tell us, well, they need to be in location X, how many days a week or a month, and location Y, how many days a week or a month, because we'll pull the data. And that's why I wanted to start with a small number, because it's going to be a very complicated shared resource. And if I did COPD, then I know I could stick one individual in one practice full-time from the get-go, and nobody else would get any access. So I need to share this one resource because that's all we could fund.
Well,
And we've done regions like your area. This
isn't new for you guys, I know.
This isn't new for us. Yeah.
But I think, learning from this integration is a way for us to build on other things that we're doing, like the PCN nurse project, and, using that data pull to say, okay, well, Claire's practice is full of diabetics, but maybe, somebody else's is actually more important related to COPD or whatever. And so the resources are not necessarily the same, but they're equitable based on patient need.
Thank you.
Awesome. All right. Well, with that, we're now at time, and I really appreciate everyone's time. So I'm going to get that email sent off so that the data agreements and other things can be responded to by the clinicians who are interested, and we'll go from there.
Excellent.
Thank you,
Thank
Marilyn.
you.
Thank you,
I'm
everyone.
so excited.
Thank you very much.
Us
Take
too.
care.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye-bye.